Welcome, everybody, and thank you for being with us today. We are here to discuss one of the most exciting new technologies in the field of vascular access, intracavitary ECG. The question we are going to ask today is, can it become the gold standard for tip location? With me today, three absolute experts on the field. Dr. Cristina Garrino from Cotolengo Hospital in Torino, Italy. Dr. Antonio La Greca from Gemelli Hospital in Rome, Italy, and Dr. Mauro Pittiruti, also from Gemelli Hospital in Rome, Italy. Dr. Pittiruti will start this webinar describing the principles and advantages of intracavitary ECG for chip location. He will share exclusively with us a brand new clinical paper yet to be published. So stay tuned. Then, Dr. Garrino will address the most apparent limitation of ECG, patients with atrial fibrillations, or AFib patients. She will describe the mechanism of it and review all the published data on the topic. Last but not least, Dr. La Greca will drive us in a practical session on how to use an intracavitary ECG monitor for chip location with AFib patients. We will close the session with 30 minutes of questions and answers. You are invited to use the chat on the right of your screen to ask questions to the panel. We'll do our best to keep record and answer all the questions at the end. My name is Marie Laforest. I'm your host. I'm an ECG enthusiast, and my main mission in Vigon is to help spread this fantastic state-of-the-art and affordable technique. So I hope you will enjoy this webinar. Dr. Pittiruti, the stage is yours.
Thank you, Marie.
Thank you.
Okay, this talk is really about a long story. A long story because the intracavitary EKG method started a long time ago. It's actually 70 years ago. And it started in USA by a German guy called von Hollerstein. And it's something that has been developed along the years in many, many papers, hundreds of papers. It's not something new. It's something old and something which has been proved to be effective. It all began in 1949, as I told you, with this paper. The paper was a very simple paper where the authors did not exactly realize the possibility of recording the intracavitary potentials for the purpose of tip location. They just found out that it was possible by filling a catheter with saline to achieve an intracavitary EKG who could be used for further research. Later on, in the late 70s and in the 80s, it started a sort of experimental investigation of what the possibility of this new technique was in the field of tip location. And the first papers were not from USA this time, were from Japan, from Germany, from Spain, and from other countries, Norwegian too. And all of these papers were curious about the technique, and they were investigating the possibility of using it at ST location. Most papers were very successful in this regard, and they found out that the method was easy and expensive. Unfortunately, the accuracy of this paper was inevitably compared with chest X-ray, which is not exactly an accurate method. Nonetheless, in the last decades, in the last 2 decades of the 20th century, the tip location by intracavitary EKG was used in many European hospitals, particularly in Germany, in Belgium, in Austria, and in northern Italy. Specifically, in our hospital, the Gemelli Hospital in Rome, we started to use intracavitary EKG more than 20 years ago in 1997. At the beginning of this century, the papers became more and more focused on the indication, contraindication of the technique. In particular, a few German studies discussed the difference between the saline column technique, which was the original technique by Hollerstein, and the wire technique, and several papers by Schumer from Germany tried to define some possible false positive of the technique and some possible pitfalls. But in this decade, the most important thing were three studies, three clinical studies, which are the basis right now, even now, for the evidence of the efficacy of the intracavitary EKG. These three papers tested the EKG method not with the chest X-ray, that has been done in the past, but directly with the transesophageal echocardiography. These three papers were published in the same years, probably without much interference between researchers, and they practically did the same thing. They compare the tip location with the intracavitary EKG, with the transesophageal echocardiography, with the chest X-ray, taking transesophageal as the gold standard. And in this comparison, they found out that intracavitary EKG was 99% accurate as compared to chest X-ray, which was accurate in less than 90% of the cases, 86-87% of the cases. In 2007, we had the first randomized control study published by Gebhardt. Gebhardt was a German researcher who worked in Florida at that time, and he published this very interesting study, the first to be a randomized study on intracavitary EKG. And then in 2008 and 2010, we had the first two studies, which became rapidly very popular, which applied this technique, the intracavitary EKG, to PIC. And 1 year later, in 2009, we had the first international guidelines who actually recommended the intracavitary EKG. The guidelines of the European Society of Parenteral Nutrition. Specifically, these guidelines stated that the position of the tip should be checked during the procedure, either by fluoroscopy or by the EKG method. In the following decade, the second decade of this century, there were many clinical studies discussing different aspects of the technique, different vascular access devices, central access devices, of course, and only in those years, the first dedicated EKG monitor, specifically dedicated to intracavitary EKG technique, really appeared on the market. Before 2009, the intracavitary EKG was performed, as it is often, even now, by standard EKG monitor. These are papers, as you see, from Italy, from Germany. Interestingly, from Italy is the first multi-center study about intracavitary EKG performed on more than 1,400 patients. But we had also many other countries, Scotland, Austria, Spain, and finally, in the second decade, also the United States started to study the technique. In this decade, these many issues became finally clear. First of all, the maximal height of the P wave really represents faithfully the carbohydrate junction. This was something which was somehow confused in the first studies because there were studies saying that probably 2/3 of the maximal height of the QRS were the ideal height, but it is not. The maximal height of the PWA is our real goal if we want to find the carbohydrate junction. The second is the concept, and this is still a quite common misconception, that the maximal height of the PWA is not related to the sinoatrial node, but it's really the transition between the electrically inactive tissue of the superior vena cava and the electrically active tissue of the right atrium. And finally, that the best way to detect the maximal P wave, avoiding false positive, as shown by Schumer, is not to look just at the very high P wave, but to look at the pattern of changes of the P wave, which should be increasing and then reach a peak and then decreasing and or become diphasic. Interestingly, in the last 4 years of the second decade, there were many papers on intracavitary ECG in China. Intracavitary ECG became very popular in China, particularly for pigs, documented by many studies, as you see, all very recent studies. The intracavitary ECG pediatrics is a rather parallel and different history. It is still a very old history because the first experience are from 25 years ago, practically only from Europe, in neonates, in children, or with different kind of devices. And starting from 1983, and then coming more closely to the end of the century and to the beginning of this century. At the end, in 2015, we have the first multi-center study about intracavitary EKG in more than 300 children. All of the study were showing the effectiveness of the technique. And in the same year, we had the first pediatric guidelines recommending intracavitary EKG from the Italian Society of Pediatric Oncology. And again, many papers from China and from Italy and from other countries. The bottom line is that they found that intracavitary EKG can be applied in practically any catheter, though with umbilical venous catheter and epicutaneous caval catheter, there might be some technical difficulty. And also in the children, the use of transthoracic echocardiography is particularly easy and accurate, so that it may become a companion of the intracavitary EKG. Another parallel story is the intracavitary EKG in nephrology, mainly based on Italian studies of the beginning of this century. And they found, all the study, they found that intracavitary EKG is also easy and accurate for dialysis catheter. With one more advantage if compared to the other catheters, the fact that for dialysis catheters, there is the possibility of comparison of between the two lumens of the P wave tracing between the two lumens. Still, we must remember that if the dialysis catheter has different holes at different distance of the tip, that might be some inaccuracy of the technique. So the state of the art is that the tip location, of course, is mandatory in all central insertion. We know that we can have a tip location method both during the procedure and after the procedure. Still, the guidelines recommend to use a method during the procedure, because the post-procedural control of tip location, as we did 20 years ago with the chest X-ray after the maneuver, is a waste of time and a waste of resources. And it should be done only in exceptional cases. So if we look at the three main intraprocedural methods that we have for tip location, these are the intracavitary EKG, which is absolutely accurate, more accurate than radiology, as shown by those three papers that I mentioned, though it's obviously less accurate than transesophageal echocardiography. It is inexpensive, it is safe, and it's easy. And the guidelines such as INS standards of practice recommend to use intracavitary EKG as the preferred tip location method. There are some limitation applicability that will be discussed by Cristina and by Antonio later, especially regarding the atrial fibrillation, though modified intracavitary EKG, as will be discussed later, can be solve this problem. The only left problem is those situations which there is no atrial fibrillation, but still the conventional intracavitary EKG may be difficult, such as pacemaker or other unusual cardiac arrhythmias. In this case, we do not recommend to use fluoroscopy. Fluoroscopy is expensive, unsafe, is not so accurate, is logistically difficult, and there are guidelines overtly discouraging the use of fluoroscopy, such as this recommendation of the AHRQ or the recommendation of INS. One possibility is the TEE, the transesophageal, but of course it's logistically difficult or impossible in many patients. It is very expensive. So we should take in consideration as I told you, as a complementary to intracranial ECG, the transthoracic echocardiography, which means to visualize by transthoracic echocardiography by different views the chambers of the heart, and with or without the bubble test, which means the infusion of saline, identify the injection close to the heart. It is a very simple maneuver, particularly simple and easy in children and neonates. And we often use it in neonates. Still, also they are very echographically easy to explore. It's not really appropriate for routine use in adults, though it may be very useful when the intracavitary ECG is not applicable or feasible. So at the end, these are our current algorithm in neonates and children. If there is a central line of 3 French or more, where the intracavitary ECG is easy to perform, we use intracavitary ECG coupled with transthoracic echocardio. For umbilical venous catheter, epicutaneous catheters, probably the easiest way is the transthoracic echocardio. Anyway, there is no reason to do a chest X-ray for this purpose in a neonate or a child. In adults, it may be different. Probably 90% of the patient will have a P wave which is evident. So we use a conventional intracavitary ECG, and we do not perform the post-procedural chest X-ray. If the P wave is not evident, which is probably approximately 10% of the patient, probably 9% will have another fibrillation, so we can use the modified intracavitary ECG. And only 1% of the patient who do not have P wave visible, but they are not atrial fibrillation patient, we can use other methods, and the best method is not fluoroscopy, is not post-procedural, but is the transthoracic echocardiography. So the take-home messages are that when we insert a central line, we must always use an intraprocedural method. We think that blind insertion by length estimation and the post-procedural chest X-ray is not acceptable anymore. It is a waste of resources, a waste of time, and also is possibly associated with damage to the patient. Please avoid fluoroscopy. Please avoid fluoroscopy, particularly in children and neonates. It is expensive, inaccurate, and unsafe. Fluoroscopy should be used only for very specific situations, such as a long-term dialysis catheter, and even in that case, it should be coupled with intracavitary ECG probably. In all central lines, in most central lines, just use intracavitary ECG whenever the P is evident. If the P is not evident, consider to use the modified intracavitary ECG that will be discussed in a few minutes, or the transthoracic echocardiography. Thank you for your attention.
Thank you, Dr. Pittiruti, for this very clear and exhaustive history of ECG. We will now hear Dr. Garrino to speak about atrial fibrillation patients.
So we have seen the importance of intracavitary electrocardiographic method for deep location. But what if there is no P wave visible? We are talking now about the intracavitary method in case of atrial fibrillation. What is atrial fibrillation? It is an arrhythmia that is an abnormal heart rhythm characterized by the irregular and often rapid beating of the atrial chambers of the heart. This is the most common arrhythmia, affecting more than 33 million people worldwide, and in particular 2 to 3% of the population in Europe and North America. The percentage of people with atrial fibrillation increases with age, affecting about 14% of over 50 years old people, which leads to an expected frequency in hospitalized patients of about 7 to 10%. Here you see an animation of a normal beating heart and a fibrillating heart in which the upper chambers contract irregularly and the impulse is transmitted irregularly to the ventricles that beats irregularly as well. How does it count? The normal electrical conduction system of the heart produces electrical impulses generated by the heart's pacemaker, that is the sinoatrial node, that stimulate the muscular layer of the heart in the atria and ventricles. When this happens in an orderly manner, the four chambers contract synchronously, the two upper and the two lower chambers, and it appears normal P waves on the electrocardiographic trace. In atrial fibrillation, the normal regular electrical impulses are absent or overwhelmed by a disorganized electrical activity, usually originating from the roots of the pulmonary veins or proximal vena cava. These waves conduct intermittently, leading to an irregular activation of the upper and the lower chambers of the heart and originating irregular waves on the electrocardiographic tracking. These waves are called F waves. Here you see the normal electric conduction of the heart. The impulse is generating by the sinus, the the sinoatrial node, and spreading to the atria and to the ventricles, and a fibrillating heart where the impulse is generated in various spots of the atria. On a standard electrocardiogram, the depolarization of the atrium is represented by the so-called F waves, that are a cluster of irregular waves located in the TQ tract of the electrocardiographic trace. The frequency and amplitude of these waves can be extremely variable and irregular. In many cases, they are undetectable at surface electrocardiogram. This is a normal electrocardiographic trace with the normal P waves, regular P waves, and a fibrillating trace with irregular waves in the TQ tract, that is the tract between the end of the T wave and the beginning of the QRS complex. Sometimes the waves they are indetectable on surface electrocardiogram. Since early 60s, attempts have been made to amplify the F wave signal with an intracavitary electrocardiography in order to better study the electrophysiology of atrial fibrillation. Here you can see one trace in a study of 1965, and the electrode was pulled from the inferior vena cava, where the F waves were very little and very regular, to the right atrium, where the F waves became very high, and pull again in the superior vena cava, where they almost disappeared. More recently, these findings have been used in an attempt to create an algorithm for the application of the intracavitary electrocardiographic method in patients with atrial fibrillation. Assuming that the F waves are the expression of the fibrillating impulses, in most cases originating from the upper part of the right atrium, it seems logical to presume that F waves could be considered some sort of surrogates of P waves, thus leading to many attempts to find a way to identify the highest voltage of the F waves in search of a correspondence with cavo-atrial junction position. Here you see, again, a representation of the heart with the sinusatrial node and the fibrillating impulses originating in various parts of the atria. Here you see an anatomical preparation in which you can find the crista terminalis, that is the anatomic landmark for the cavo-atrial junction. And you can see the root of the pulmonary veins is projected in the superior part of right atrium. Sorry. Here we come to the studies. This is a 30 years old German study with made for trying to utilize to use the intracavitary electrocardiographic method in fibrillating patients. An electrocardiographic recording was made intracavitary with a copper wire in a catheter through the superior vena cava, right atrium, and inferior vena cava. 40 patients were enrolled, and all electrocardiographic traces with high voltage F waves matched with the position of the tip in the right atrium or in the cavo-atrial junction. In 2011, the group of Gemelli, Policlinico Gemelli in Rome began again to study the possibility of using intracavitary ECG method for the fibrillating patients. At the beginning, the X-ray control was the standard. In this study presented at the AVA Congress, 27 patients were enrolled, and the method, the method had high accuracy and a few false negatives. 2 patients have had a trace not detectable, but the catheter was correctly positioned. Okay, here are many other studies. In the meantime, in 2018, it was a German study. This is a Chinese study in 2018. This is another Italian study in 2019. But all these studies used chest X-ray as a control that we have just seen. It's not the gold standard, because we know that the gold standard for controlling correct positioning of the catheter tip in cavo-atrial junction is currently considered transesophageal echocardiography. Here you see one image of a mid-esophageal bicaval view. You see the right atrium, the inferior vena cava, and the superior vena cava. And this is again the anatomical preparation with the crista terminalis, the atriocaval junction, and the root of the pulmonary veins. Finally, a study just published in 2019, that was based on a preliminary pilot study, always from the same group of Pittiruti, La Greca at Policlinico Gemelli, Roma. In this last study, 18 consecutive patients were enrolled, presenting atrial fibrillation and requiring simultaneously the positioning of a central line and transesophageal echocardiography. A intracavitary trace was recorded with the catheter tip in 3 different positions. First position is in the superior vena cava, 2 centimeters above the cavo-atrial junction, or at the cavo-atrial junction, it has the crista terminalis, or in the right atrium, 2 centimeters below the cavo-atrial junction. Here you can see the images, right atrium, vena cava, superior vena cava, inferior vena cava, and crista terminalis. Here is the tip of the vascular access device in correspondence of the crista terminalis. Here is the tip in the right atrium, and here is the tip in the superior vena cava. you can see the recording of the electrocardiographic trace in superior vena cava, cavo-atrial junction, and upper right atrium. You can notice the F waves are much higher in cavo-atrial junction, but the three different criteria of measurement were utilized for measuring the pattern, the F waves, the mean height of all F waves, method A, the height of the highest F wave, method B, and the difference between the highest peak and the lowest negative peak, method C. Then each parameter was recorded for 10 cardiac cycles and then reviewed by the physician that didn't knew in which position was recorded the trace. So it was read in blind. Here you see method A, a mean of the height of the F waves, the highest F wave, method B, and the difference between the maximal positivity and maximal negativity on F waves, method C. With the tip placed in the cavo-atrial junction, the F waves were significantly higher than in other two positions, with all the three measurement methods. Okay, and with the statistical curve analysis, method B proved to be the most accurate as it had the lowest false positive and lowest false negative results. This study has demonstrated that the modified method of intracavitary electrocardiogram, based not on the maximal weight of the P wave, but on the maximal electrical activity of the TQ tract in the so-called F waves, can be safely and accurately used for detecting the location of the peak of the tip of central lines. These results also suggest that this method should replace other tip location, as Mauro said just a few minutes ago. And this can be one more card in our hands to play to do better with less harm.
Okay, so I hope to give you some tips and tricks for the use of a specialized monitor, helping you in dealing with intracavitary ECG in atrial fibrillating patients. As Mauro and Cristina showed you, intracavitary ECG might have problems, sometimes might fail. This happens not only for atrial fibrillation, but even with some other conditions that we will deal with after in a short while. And even because sometimes standard monitors do not provide a good and correct signal transduction, so giving problems to the operator to correctly read and interpret the signal. So, as you know, current guidelines give some kind of contraindications in the use of ECG technology when patients haven't got a clear P wave. And indeed, atrial fibrillation is frequent in older people, and this accounts for a rate of global applicability of the method which doesn't reach 100%. And we have some kind of unfeasibility when patients who have a P wave still have problems that made the interpretation of the trace difficult. By the way, as Mauro told you, we still want to avoid X-rays because of international recommendations stating that this should not be done. So we have a couple of strategies to improve the results of intracavitary ECG in patients which are unsuitable for it. And we can do both, improving signal detection and improve applicability with some strategies and some new devices. But let's talk about the striking point, the modified ECG. As Cristina showed you, In our latest study, we demonstrated that a maximal activity that we can detect and measure when the tip is close to the atrial junction, even in fibrillating patients, exist and can be used to detect the correct tip location even in these patients. And the studies that Cristina showed you that indeed reinforce the concept that we can use a modified ECG in fibrillating patients still have some bias, not only because they compare the ECG to a non-standard method and a non-recognized method, such as the transjugular ultrasound or chest X-ray, but even because they use a qualitative TQ assessment. So they, in these studies, the operator says, well, this trace is higher than this, but they are not able to say how much. This is the reason why we underwent a further study with the hypothesis that using specialized digital ECG monitors to calculate, not only to visualize, but to calculate the highest TQ value during the procedure might help the operator to better detect the atrial junction in fibrillating patients. We chose this device. We have been working on this device since many years, and we are cooperating with Vigon since at least 2 years. The hypothesis is that a device like this that might provide automatically the measure of the widest difference between maximal positive peak and maximal negative peak, if you remember, this is the method C in our study, might improve applicability of the method, and a good device can assure a good signal detection and interpretation, thus increasing feasibility of the method. This is the device we are talking about, and this is the new shape, the new device with the new dashboard. This is an intermediate version of the device with the old dashboard. The old dashboard that we still use for research purposes because it helps us to get a lot of values and numbers that are useful for, as I told you, for research studies. But this is the new dashboard. This is for the user, for the final user, and it should be user-friendly with some commands in the lateral aspects of it, with the possibility to freeze the image and to get the data of the patient, to print, to save, and to change some features of the image in the screen. As an example, this is a standard visualization of the P wave as compared to the QRS, and this is a way to amplify the P wave and see it better, to better visualize the changes in its shape while advancing the catheter. This is what happens in atrial fibrillation. This is a standard visualizations in the so-called P mode, and shifting to the F mode, the machine is able to get down the noise, and so let the operator better see the F waves. This is the modern shape of the device. This is the way how we connect it. As you see, we have the standard situation of the electrodes, but the yellow one is not connected until you need the intracavitary ECG properly. This is because the idea is that in the D2 lead, which is the main lead we have to examine, has this direction, and if we have the catheter inside the heart, the secondary lead, this one, will read the trace in a parallel fashion to the standard D2. So this will be the basic trace, and this will be the intracavitary one. When we are far from the heart, they're quite the same, and this improves the results. This is only a particular to let you see that a standard cable can be used to connect the system to the monitor. So this is what happens when you look at the standard patient. You have a clear trace, and the system identifies the P wave and differentiates it from the QRS. And this is what happens in atrial fibrillation. This is a static picture, and the system, as you can see, identifies the maximal positive and the maximal negative peak of the trace in every TQ segment. And this is what happens while moving. We are far from the heart here. We are approaching the heart in this part of the trace, and the system identifies the maximal differences in the positive and negative peaks of the P wave in every TQ segment. We are in the fibrillating mode, so this mode is filtered and allows you to better see the shape of the trace. And the system as well gives you a value. We are working on this value. Why? We tried to test the effectiveness of this device in identifying the magnitude of fibrillating waves as compared with the manual measurement that you saw in our previous study, and the ability of the system in identifying automatically the proper tip locations. What happened was that the pilot was not so correct in identifying the F waves when the tip was far from the heart. When the tip was close to the heart, it was able to identify correctly the different position of the tip. The reason for this was that you must consider that the T wave exists. And in some patients, the F waves run around the T wave. Now, this machine was not projected to recognize the T wave, so it was not so accurate in identifying the correct position of the tip when it was far from the heart, where the basic trace was low, and so the machine identified the T wave as a high F wave. It was accurate while identifying the position of the tip when it was close to the heart, because in this position, the T wave usually has the same amplitude of the F wave. We are working on the machine to let her exclude the T wave in its calculation, but so far the pilot remains one of the best devices available because it gives you an excellent signal quality and the chance to manipulate the signal to improve interpretation, such as when you want to increase the amplitude of the F wave to better see them as compared to the QRS. Still, it is the most promising machine because it is the only one providing quantitative measurements on which we are working to give a standardizable parameter to let the operator use the machine to automatically detect the atriocaval junction position. So can we improve this ECG results? Yes, we can integrate all the above measurement strategies. I mean, we can use new devices to improve the signal detection, and we can use new devices to better use the modified ECG. That's the reason why we use an integrated algorithm, as Mauro showed you. And so the answer to the question is, can we improve ECG results? Yes, yes, we can, and we can using our brain and some new devices. Thank you.